acute kidney injury, prescribing CRRT in 2024, a contemporary overview. And to deliver this talk, we have none other than Dr. Dinesh Khullar. He is a chairman of Nephrology and Renal Transplant Medicine at Max Saket Complex, New Delhi. I think he's not new to all of us. We all know him, and let's see what he has in store for us.
Good evening, everyone. At the outset, my sincere thanks to the organizing team for this wonderful opportunity. It's a pleasure to be here in this wonderful city. And as Manoj was saying, shifting gears, and yes, we are shifting gears and talking about something which is equally important to all of us as nephrologists. When Dr. Rai told me that I'm supposed to be delivering a talk of 45 minutes duration, let me confess the title of this talk was Prescribing CRRT in 2024, a comprehensive review. And when he finally told me, no, you are just allotted 15 minutes, I changed the topic and made it a contemporary overview. And let me try to see how much can I really fit it into these 15 minutes. We're all aware about what CRRT stands for. I will not go into the controversies because it's been actually mired into so many of them ever since we started using CRRT, and we were always told, why this expensive therapy when you can achieve same kind of outcomes with the help of SLED. I will not go into controversy, having been convinced over the years that CRRT has a niche place, has a definite role to play in our critically ill patients. And the way when I was listening to wonderful talk by Professor R.K. Sharma, it didn't require the trial to convince me about the advantages of online hemodiafiltration. In the same breath, I would say I am quite convinced that CRRT is a wonderful modality of treatment in our critically ill patients. And these are typically the various kind of modalities which we are all familiar with. And when it comes to the advantages, we know there are set advantages, which again is something which all of us as nephrologists are quite well aware of, and especially keeping in mind the hemodynamic instability of these kind of patients. Well, there are certain disadvantages as well. It's a very slow modality of treatment, and it'll ensure only a slower toxin clearance. It'll need a lot of perseverance, a lot of training of our technical staff, and you have to be quite careful about what kind of problems and nuances you have to deal with while dealing with the patient of CRRT, undergoing CRRT. Well, typically, how long should you be doing CKRT? The moment we talk about CKRT, the first thing which comes to mind is going to be a prolonged therapy. Prolonged means at least 24 hours, but it doesn't end there. So many times we find ourselves going uninterruptedly over many days, especially if the circuit doesn't get clotted. You will find typically yourself persisting with CRRT over the next many days. And it all depends upon when does renal recovery take place. That's one, are you going to incorporate ECMO in the therapy of a critically ill patient? And certainly the overall condition of the patient will decide how long do you persist with the CKRT. Well, why choose? And as I said, not raising this kind of controversy one more time, but yes, to put things in the right perspective, we need to know why are we actually going in for this costly therapy. Well, so many times as we know, the severity of and the kind of patients which we are seeing and their severity of illness, often we come across patients who have multi-organ failure, who have a lot of hemodynamic instability, and imagining them to be put on conventional dialysis is unimaginable. So that is why we want a steady removal of solutes, which enables this form of therapy to achieve greater azotemia control and symptoms control. Longer treatment time in CKRT with a continuous supply of buffer provides better metabolic profile in your patient as far as the acid base and the electrolyte imbalance is concerned, and it also offers more precise fluid balance to be achieved in these patients. And of course, you can also significantly think about giving them proper nutrition. So why CKRT? Well, there are many positives attached to CKRT, and a superior volume control, as is seen in this picture, is one of them. Well, intracranial pressure changes is the first thing which comes to mind. The moment you come across a patient with acute brain injury, a massive IC bleed, or a liver failure, the first thing which comes to mind in a patient who is hemodynamically unstable is the CKRT, because of very little chances of significant intracranial pressure changes when you put these patients on this modality of treatment. Well, these are the classical indications which you would always keep in mind when you are wanting to put your patient on CKRT. We are all familiar with what any kind of dialytic support will do to the potassium control, the acid control, acidosis control, and the kind of volume balance you can achieve, especially in patients who are oligoanuric. But there are specific indications when it comes to CKRT, and when you want to treat severe dysnatremias, be it hypo or hyper, that's something which comes to your mind. Intracranial hypertension, as I said a short while ago, cardiopulmonary failure requiring especially ECMO, the first thing which comes to mind is CKRT as the additional support. And of course, when it comes to organ support in patients with more advanced heart or liver disease who are definitely unable to tolerate intermittent HD, you would keep CKRT as one of the specific indications in these kind of patients. Well, also in patients who require a continuous solute removal, especially in the cases of malignancies where you have high cell turnover or cell lysis like rhabdomyolysis, you would want to put CKRT as the preferred modality of treatment. And another very peculiar indication, when you have done a challenging task of subjecting a patient of primary hyperoxaluria to a combined liver and kidney transplantation, so many times you would want yourself putting your patients on CKRT for removing that extra load of oxalate till the time the system falls in place. Well, this is most important. This is why, because there is importance of timing of fluid replacement in CKRT. As we know, initially we pump in a lot of fluid in patients who came to you in shock state, and then there is a maintenance or a decelerating phase followed by equilibrium phase, and then finally mobilization. And this is what happens when you are putting your patient on CKRT as well. Well, timing has been controversial. We have a long list of various trials which have tried to address this issue as to when to start CKRT. But ultimately what we realized is it's your experience. It's that patient in front of you in the intensive care unit where you will use all your experience over the years to decide when to act. Too early may be bad, and too early, too late also is equally bad. So you have to be acting at the right time. And when do you stop? Again, the patient's clinical situation will tell you now is the time to stop. Again, you need tremendous experience. It may look very easy, but then when you finally have to take that decision, you struggle at times. Whether you are wanting to give anticoagulation to your patient, again will depend upon whether your patient has bleeding tendencies or not. So, moving further, these are the typical trials which we have in mind. And just to recapitulate every nephrologist and critical care experts' knowledge about what we have learned, whether early is good or bad or late is good or bad. ELAINE and START-AKI typically took patients, enrolled patients who were in stage 2, and they compared these patients, especially with ELAINE, in those patients who had reached stage 3. They were surgical patients in ELAINE, and what these trials over the years have shown us is that early, except for ELAINE trial which showed acting early in these patients who predominantly had surgical causes of AKI, was a good strategy, while all others said it doesn't make a difference. So what we have learned over the years is use your wisdom to not do it as a knee-jerk reaction. At the same time, do not delay it before it's too late. So this is what these trials have also shown. Well, the anticoagulation bit is important. So as I said at the outset, this is going to be an overview. All of us who have been using CKRT are well familiarized with what I am talking at the moment, and anticoagulation is certainly an integral part what we have to decide on a daily basis, whether to give it or not. And the guidelines say wherever it's possible, use regional citrate anticoagulation as the modality of anticoagulation rather than the conventional heparin. Well, if you do not want to use citrate, if there is any contraindication to the use of citrate, as we'll discuss later, you may opt for both fractionated or unfractionated heparin, but try to avoid other kind of anticoagulants. Well, we also are familiar with what can go wrong if we are using regional citrate anticoagulation and are not familiarized with the nitty-gritties and what all can go wrong. As you can see in this slide, if there is an excess buffer from citrate, you can expect a total calcium, ratio of total calcium to ionized calcium to be less than 2.5. The same ratio will be less than 2.5 even when there is an insufficient buffer, as you can see in the lowest panel. But the treatment is different, because on one hand, if you give excess of citrate, either you are giving it and obviously there is going to be conversion of citrate into bicarbonate, you can expect metabolic alkalosis, and you will actually find yourself reducing the blood flow rate and probably reduce the buffer concentration in other CKRT solutions. While the important thing here to remember is that if there is an insufficient buffer from citrate, that means you are not able to provide adequate citrate supply. Again, you will find a ratio less than 2.5, but in stark contrast to the first scenario, you are finding metabolic acidosis in this scenario, and you would want to increase blood flow, you would want to decrease dialysis rate and increase the buffer concentration. So those who are familiar with usage of regional citrate anticoagulation are, I'm sure, quite familiar with the kind of challenges we face on a daily basis. Now about the use of the vascular access, this is very important. We are all familiar with what we normally do, right jugular as the first choice, followed by right femoral, left internal, left jugular vein, and the last choice would always be a subclavian. This is what we have learned over the years. Typically 11 to 12 French size of the catheter, but if you have to remove carbon dioxide extracorporeally, maybe you would want to go in for a wider 14 to 16 French catheter. Now, which modality? Now again, when you say CKRT, the first thing which comes to mind, it's convection as opposed to diffusion, unless you are going in for CVVHDF, which means it's a combination of diffusion and convection. But what is the modality you choose? Always treat them as complementary to each other. So many times you'll find yourself shifting from one to the other as and when the clinical situation changes. And the recommendations by KDIGO are to use CKRT rather than intermittent in patients who are hemodynamically unstable. And that's the essence. That's why we are talking about CKRT. So again, when it comes to acute brain injury and other causes, and I think this is what I and Dr. P.K. Rai were discussing when Dr. Rai, who seems to be a little busy at the moment, when we were talking about the kind of topic he had in mind for me. So this is one particular area which we concurred that we think about CKRT the moment patient of liver failure comes to us, hemodynamically unstable and having some kind of intracranial edema after bleed. Well, you would rather be finding yourself using bicarbonate than lactate, especially in a patient who has circulatory shock, severe shock, and has already evidence of lactic acidosis. And you should make sure that you conform to the Army standards when you are looking at the sterility of the dialysis fluids which you are taking. The dose, typically, we all know something like 3.9 of KT/V on a weekly basis. But when it comes to CKRT dose, we have realized that 20 to 25 is good enough. We don't have to really try and achieve more than 35 or 40. But to be able to achieve 20 to 25 and taking care of the downtime, time lost and so many other factors, you would typically want to try and keep it between 25 and 30 to take care of the necessary stoppages in between. So So what we have realized is more than 35 doesn't offer you anything better. Be happy with what you are able to achieve if you are able to deliver an effluent volume of 20 to 25 ml per kilo per hour. So this is the dialysate flow rates. As you can see here, when it comes to CVVHD, which is diffusion, you would be more interested in increasing the volume of dialysate, and you can actually expect some kind of increased solute clearance. But when it comes to hemofiltration, as you can see in the lower panel, the solute clearance with CVVH, it depends upon the effluent volume. So when we are talking about CKRT, you all know that we talk about CKRT. I think Dr. Manoj, Dr. P.K. Rai just informed me he had given me 5 extra minutes because of the time lost initially. So maybe I think he'll stick on to his words. So I'll need just about 5 more minutes. The ultrafiltration, as you know, is important. As you can see in this chart, what is ultrafiltration? It's the difference, the net ultrafiltration is the difference between ultrafiltration minus what we have actually given, the replacement fluid and the dialysate volume. And what is important to remember here is that if, as you can see, the net ultrafiltration rate is less than 1 or is more than 1.75 milliliters per kilo per hour, which means typically about 60 ml to 100 ml per hour, that's the safe range. Less than that is not good for the patient. More than 100 in typically a 60 kilo patient is again not going to be a good news for your patient in the long run. Appropriate blood flow rates, we all know in the setting of CKRT, you would want to. Now remember, this is for the young impressionable minds if they are here or logged on to us via YouTube. Remember that the rule is you would want to keep the blood flow rate 2.5 times more than the dialysate rate so that you allow effective exchange at this point in time. If it comes to CVVH, you probably would want to keep in the pre-filter state blood flow rate of more than 6 times the dialysate rate, the substitution fluid rate. And when it comes to post-filter, 5 times more than the substitution fluid rate. So what are the factors which affect the filter life? Well, the access is important and the circuit. Now in the circuit, if you have employed CVVH-DF or CVVH-D, it definitely is preferred modality because there are 44% chances that the circuit will clot, less likely to clot as compared to CVVH. And of course, the type of catheter which you use, and of course is equally important is the dose. You keep the blood flow at a higher rate, you give a higher dose, and you do not ignore the kind of ultrafiltration rates which have been advised. You will probably find the filter life to be significantly improved. And these are the factors: a lower pH, a higher APTT, and when you mobilize these patients, these are the ones which can have positive influence on the filter life. While if your patient has elevated fibrinogen and platelet count and is requiring transfusion as a higher SOFA score, you probably will find the filter getting clotted earlier. Now, what are the potential applications? AEIOU is what is easy to remember. Acidosis, where typically if pH is less than 7.1 or bicarbonate less than 15. Electrolyte imbalance, as we have already talked about. Intoxication, we all know that for intoxication, intermittent hemodialysis would be better, but so many times if patient is hemodynamically unstable, maybe you would want to employ CKRT in these patients. Volume overload certainly is taken better care of if you have employed CKRT in your patient. And of course, the uremic, the manifestations in the form of encephalopathy or pericarditis. Now, a word about sepsis. We all know what sepsis is. Well, just to conclude that CKRT use should appropriately support different organs like kidney, liver, lungs, heart in hemodynamically unstable patients with septicemia, especially in the intensive care unit, because we believe that CKRT may better facilitate recovery of kidney function as opposed to other modalities. Well, in cardiac surgery, there's a term now, cardiac surgery associated AKI, and based on the different definitions, the incidence is something to the tune of 20 to 30%, depends upon the time on cardiopulmonary bypass, and it is a recommendation that if you use KDCO-based AKI bundle, you can expect a significant reduction in the AKI incidence. So that's as a good thing for the cardiac surgeons. And this is a very recent article in JAMA which says that the use of non-selective extracorporeal blood purification devices, if you have used in the cardiopulmonary bypass circuit, this is going to be a good news for your patient, especially causing a significant reduction in AKI in the first 7 days. Now, AKI can cause respiratory failure, and on the other hand, ECMO, whenever you employ ECMO, and we find ourselves using ECMO more and more often, especially those where the facility is available, ECMO can cause AKI for the various reasons, as you can see on this slide. For the paucity of time, I'm slipping. But coming to something very important, which we are called as nephrologists very often to address the issue of liver failure, AKI in liver failure, and that's we know because of the renal hypoperfusion and so many things which are quite peculiar to patients with liver disease. You will find it a struggle to adequately treat them, optimally treat them, and it has been shown that CKRT is the preferred modality of treatment, at least in this subset of patients. It certainly gives rise to a significantly lower incidence of intracranial hypertension. And again, it is no different when it comes to treating and meticulously treating your patients with a very significant dysnatremia, be it low or a high sodium value. We all know that if you pump in too much of fluid, it is not going to be a wise decision, a wise thing to do, because you may end up seeing your patients in fluid overload, and CKRT offers an advantage where you can actually very fine-tune the volume status of your patient. Now, the problem is the hemodynamic instability, HI, which is associated with KRT. Now, what it depends is, there's a fluid in the third space, and the moment it comes back into the intravascular space, there's going to be a plasma refilling. Now, this and the difference between the ultrafiltration rate and the plasma refilling is going to decide whether your patient becomes hemodynamically unstable or not. Please do keep this entity in mind when we are optimizing support, the extracorporeal support to our critically ill patients. So to conclude, ladies and gentlemen, many ICU patients are, as we all know, hemodynamically unstable and develop multi-organ failure, typically AKI as well, and require extracorporeal support. Sepsis is certainly the most common cause and something which we always struggle with, and we take pride in the fact that we as nephrologists are always looked upon as the saviors as far as this particular condition when sepsis gets complicated by AKI is concerned. AKI is an independent risk factor for respiratory failure, and vice versa when you use ECMO in these patients with 2 to 3-fold increased mortality when one complicates the other. And of course, to conclude, management involves treatment of the underlying cause, thorough through timely administration of medications and appropriate use of KRT modality, appropriate fluid resuscitation, appropriate is the key word here, and a lung protective or support devices. So KDIGO, no doubt, rightly so, I would reiterate, recommends use of CKRT in hemodynamically unstable patients as well. CKRT modalities can be used in different situations, and I hope over the last 15 or 20 minutes I've been able to press home the point that it is certainly a very useful modality, and we should keep it away from the unnecessary controversies which it has found itself mingled in over the last so many years, ever since we started using CKRT in our country as well. Thank you very much for your patient listening.
Thank you, Dr. Khullar, for summarizing the issues in the management of acute kidney injury and CRRT in ICU. So in the paucity of time, so maybe we don't have much time for question and answer. So we may close this session here and request the organizers to take over from here.
Thank you very much.
Can I please request the faculty to come on the dais for the felicitation? I'll request Dr. Hemant Kumar sir to please felicitate our chairpersons and speaker. Thank you, faculty. So with this, we are moving ahead with our 7th session, which is transplant in complex scenarios. And I welcome and invite our chairpersons on the dais. I welcome Dr. Pradeep Kumar Dole, Professor, Nephrology at JMCH Guwahati. Dr. Praveen Pandey, Head and Chairman, Urology, Robotics and Renal Transplant at Chandan Super Speciality Hospital, Lucknow. Dr. Jitendra Pratap Singh, Chairman, Urology and Renal Transplant at Chandan Super Speciality Hospital, Lucknow. Dr. Aditya Sengar, Consultant Urologist, Uro-Oncologist and Kidney Transplant at Precision Urology Hospital, Lucknow. Dr. Vivekanand Jha, Professor, Nephrology and Transplant at Sri Ram Murthy Samark Hospital, Bareilly.
Good evening. It's good to see we are getting geared up for the evening, and I keep this session reserved for a really hot topic. We have been speaking about AV fistula, interventions, plasty, and I thought, yes, vascular does involve transplant as well. So why not talk about some complex scenarios? So what we'll do, looking at time also, so we have 2 speakers and one of our resident from department. So Dr. Naila will be setting up stage by putting 2 different case scenarios about renal transplant and aortic either anomaly or pathology. And then we'll be moving on to the first talk, which is by Dr. Jason Chua. It's an online talk. And then Professor Anand Kumar could not make it here, but he has sent his, he is right now in Ayodhya, so he cannot attend on phone, but he has sent his pre-recorded entire talk, so we'll be running that after that. So Dr. Naila Khan